So the hepatorenal syndrome, HRS, aka occurs exclusively in patients with decompensated cirrhosis. HRS, aka is considered the most advanced manifestation of circulatory dysfunction characteristic of which responsible for development of ascites and edema, and pathology revolves around cardiac dysfunction, renal blood flow, cirrhotic cardiomyopathy, and systemic inflammation. So this is the pathology of hepatorenal syndrome. It is a low effective arterial volume that reach to the central nervous system, causing a RAS activation and antidiuretic hormone release. So because of this, because the portal pressures are high, splanchnic vasodilation occurs. So and because of bacterial translocation and cell death, these all causing systemic inflammation. This all lead to sodium excretion is decreased, water reabsorption is increased, renal vasoconstriction occurs, and decrease in glomerular filtration rate. So this is the whole physiology of cirrhosis in portal hypertension and advanced cirrhosis in portal hypertension. Diagnosis of AKI. How you do diagnosis of AKI in cirrhotic patient with ascites? Elevated creatinine, more than 50% increase from the baseline of serum creatinine. Yes, if it is there, so it is AKI. If no baseline creatinine, repeat serum creatinine, more than 0.3 milligram per DL of increase in creatinine on admission, it is AKI. Stable, evaluate for CKD. Decrease in creatinine less than 66% from peak creatinine, resolving AKI. Baseline serum creatinine, stable serum creatinine for 3 months. If not available, a stable serum creatinine closest to current one. That is what is currently, and that is stable for 3 months. It is called the baseline creatinine. If no previous serum creatinine, use the admission creatinine is the baseline creatinine. Stage AKI. So this is stage 1, stage 2, stage 3, as you already mentioned and understood. They found that based in new AKI criteria, more than half of patients with LC admitted to hospital had AKI. Not surprisingly, HRS and ATN were more common in patients with stage 2 and 3 AKI. Discontinue use of diuretics, beta blockers, potential nephrotoxic drugs. Reduce the dose of lactulose if diarrhea is excessive. Patients who have actually lost the blood should receive a blood transfusion. Septic workup and empiric antibiotic therapy should be started for the HRS patients. Okay. Diuretics should not be used. Beta blockers should not be used. Nephrotoxic drugs should not be used. Response to treatment. How you think that what the treatment you're giving is responsive to not? If it is stage 1 AKI, according to the cirrhotic, advanced acute cirrhosis, kidney injury in a cirrhotic patient. Resolution, stable, progression to stage 2, stage 3. If it is that, then the patient is improving. If not, stage 2, stage 3, yes. If no, then evaluate for HRS and intrarenal and postrenal AKI. Exclusion criteria. So how you exclude that this is not an HRS or this is something else? So 24 hours urine protein more than 500 milligram per day, microhematuria, abnormal renal finding on USG. Start injection albumin 1 gram per kg per day for 2 days with this body weight. If this AKI is resolved, yes, closely monitor. No, it is HRS. Treatment of HRS, what you do? Start terlipressin or plus with albumin or octreotide midodrine and albumin or noradrenaline and albumin. No response, partial response is creatine, decreasing creatine from to a level of more than 0.3 milligram per DL. Complete response is decreasing creatine level within 0.3 milligram per DL. Pharmacological treatments, you can give a renal vasodilators by antagonizing the endogenous effect of renal vasoconstrictors. Okay, unfortunately, this is not beneficial, and so this is abundant. Systemic vasoconstrictors can be given like terlipressin, somatostatin, and alpha-adrenergic agonist. This rely on the assumption that interrupting the splanchnic vasodilations will subsequently relieve the intense renal vasoconstrictors. Albumin is recommended solution as it not only has a volume expanding property but also has been shown to have antioxidant anti-inflammatory properties. The dose of albumin in HRS treatment has not been well established. Albumin has been used intravenously at mean dose of 20 to 40 gram per day. Terlipressin is a V1 receptor of vascular smooth muscle to cause a vasoconstriction, both systemic circulation and splanchnic circulation, dilate intrahepatic vessels, thereby reducing Reduction in portal pressure, which has direct beneficial effect on renal function in cirrhosis. Terlipressin has been studied in several RCTs in patients with HRS1, comparing bolus dose of terlipressin plus albumin versus either albumin alone. All studies show that terlipressin was able to significantly improve the renal function in 24 to 80% of patients. However, overall terlipressin is considered effective in 40 to 50% of cases. The median time of HRS reversal is 7 days, faster recuperations in lower serum creatinine at presentation. Side effects of terlipressin is systemic side effects like ischemic side effects, approximately 30%, continued infusion rate of bolus with causing fewer adverse events. Recurrent HRS responders after end of treatment has been reported 20% of cases, so the recurrence rate is 20%. Norepinephrine, noradrenaline given by continuous IV infusion at a dose of 0.53 milligram per hour has been proven to be effective as a terlipressin regarding to increase the mean arterial pressure. So noradrenaline is a basic. Whenever you find a shock, for AKI you start with terlipressin. If the patient is shocked, start the norepinephrine. Midodrine for the patient who is in a ward. If the patient is for the patient who is in AKI, can start with midodrine with albumin and showing a very marvelous effect on the improvement. If you start with terlipressin, albumin, and midodrine, we're showing a marvelous effect. Type 2 HRS is a vasoconstrictor, in particular terlipressin in association with albumin have also been proposed in treatment of type 2 HRS. The treatment has been proven to be effective in most cases, but unfortunately recurrence after withdrawal of treatment is the norm. So the most relevant factor that may impair the response of vasoconstrictors are the baseline value of serum creatinine, the degree of inflammation, the degree of cholestasis. Recommended dose, these are recommended dose of vasoconstrictors. The terlipressin dose is initially 0.5 milligram intravenously over 4 to 6 hours. If no response, day 3, 1 milligram, 4 to 6 hours, that is QID, or 2 milligram, 4 to 6 hours QID. Maximum duration is 14 days only. Continuous infusion can be started. Norepinephrine is a basic dose for the shock patient. Combination of midodrine octreotide do with a marvelous effect. Mars is another therapy that can be used but has no improvement and no better outcome after using this also. Tips for the management of HRS1, HRS2 is a decade ago, but the harmful effect is the hepatic encephalopathy. Vasoconstrictor in conjugation with tips was evaluated in studies. First study included 14 type 1 HRS patients who received oral midodrine, octreotide, and albumin, followed by the tips insertion in stable patients who respond to vasoconstrictor. So the combination therapy of vasoconstrictors, albumin, and octreotide and midodrine show a good effect in type 1 patients. So this is a diagnostic criteria of HRS, AKI. This is important to remember. Diagnosis of cirrhosis and ascites. Diagnosis of AKI according to ICA AKI criteria that I've already mentioned in my initial slide. No response after 2 consecutive days of diuretic withdrawal and plasma expansion of 1 gram per kg per day. Then it comes in a HRS criteria. Absence of shock comes to HRS criteria. No current use of nephrotoxic drug, HRS criteria. No microscopic sign of structural kidney like this. So it means if we remove all this, then the patient is put in a criteria of HRS. This is the classification that I already mentioned for HRS1 and HRS2. HRS1, this is the urine output and increase in serum creatinine. HRS2, AKD for the acute kidney disease, GFR, and HRS for non-acute injury. This is a percentage of serum creatinine increase, and HRS for CKD for the GFR is less than 60 ml per minute per 1.73 meter square.